Welcome to a webinar given by the Scoliosis Research Society on safety and considerations in adolescent idiopathic scoliosis surgery. We are going to have a question and answer period at the end of this talk. We also are going to ask you a question and answer your question shortly. So the journey from this with a scoliosis to this with rods in the back and a successful surgery is a long one. We all in the SRS are dedicated to trying to make that journey as safe and as minimize the unpleasantness of it as much as possible. Surgery is a team sport. When you have surgery, there will be surgeons there, anesthesiologists, nurses, and technicians, and the team's goal is to make your scoliosis surgery as safe as it can be. The purpose, just a quick disclaimer, this is for educational purposes only. What we present tonight is one way, not necessarily the only way to treat some of these conditions, and the best person to answer questions you may have is the surgeon that is taking care of you. We have a number of distinguished speakers tonight who are going to talk about some of the more common concerns of people who are considering having scoliosis surgery. These include neurologic complications by Dr. Garg, infection by Dr. Lark, and blood loss by Dr. Bonfield. I'm Bill Phillips. I'm the monitor. I'm the chair of the Patient Education Committee. We have a quick poll question that we would like you to try to answer. The question is, what complications are you most worried about? The question appears here on your screen. You can select your answer and hit submit. And in a short period of time, before the end of the webinar, we'll share the results with you. So please click out the one that you want. Unfortunately, there is no fill in the blank on this. I'm going to close the poll now. Well, there we go. So here we go. We've got some answers already. Neurologic, infection, and blood loss. We're not going to have time to talk about pain tonight, but that can certainly be the topic of another session that we can have. So our first speaker. Okay. These are our disclosures, nothing of relevance to this talk. Our first speaker is Dr. Garg from the All India Institute of Medical Sciences in New Delhi. He is a very experienced spine surgeon, and he is going to talk about the neurologic issues in scoliosis surgery. Dr. Garg.
Good morning. So I will be covering the neurological aspects of the scoliosis surgery, and as we just looked, the most of the patients and their families, they are worried about the neurological complications. So I think I'm going to raise off your concerns very much through this talk. So we know that the scoliosis as such is the most common spinal deformity, especially in the school-age children. If we look at the overall prevalence, it's around 0.4 to 5% of the population, and somehow it's more common in the girls, and then it increases substantially with increasing age. And if we look at the curves with higher angles or the higher deformity, it's substantially more common in girls than in boys. That means the girls, they usually require surgery much more often than the boys. And if we look at the adolescent idiopathic scoliosis, that means the scoliosis which is occurring between the age of 10 to 18 years, they account for approximately 4/5, that is the 80% of the total scoliosis cases. Now we have very sophisticated instrumentations, so we can have better corrections, and the chances of a non-union is also very less, and with these instrumentation, we can have actually recovery is also become faster. But the question is whether it has become much more safer. So the good news is that the spine surgery or the scoliosis surgery, it has become quite safe now. And why I'm saying this? Because we have the data we have from our Scoliosis Research Society, and this was founded in 1966, which is with the first specialty specific society. And all members since 1968, they fill all their annual complication report, which is known as the morbidity and mortality report. And the last report we have got from 2016, and which has reported the complications from 2009 to 2012 of all their members. So what does it say? The chances of neurological complication is actually quite less. And if we look at this thing, this is quite less. This is less than 1% or less than 0.5% in most of the cases, in most of the series also of the SRS data. So it is important to know that there is a risk of neurological deficit is always there whenever we are doing any scoliosis surgery, but it's quite minimal. But we cannot prevent it entirely, but we can have to take precautions. While the importance of the parental consent is there, because the patients, they must understand the risk, and the patients are basically children. They are not legally sanctioned, but it is also very important to understand by their families that there is a small, but there is a very small risk of neurological complications. And then the patients or their families, they tend to go for medical legal litigations also if any neurological complication occurs, if they have not understood the risk of these complications. Now, it is very important to understand that why this neurological deficit can occur in scoliosis surgery. Sometimes if there is a misplaced screws or any bone piece which is directly causing the spinal cord injury, when we are correcting the deformity, when we are distracting it, or when we are compressing it, then it can lead to the distraction or the compression of the spinal cord. Sometimes when we are correcting it, the local blood supply of the spinal cord, it can got damaged. The spinal cord blood supply can also be damaged because if there is a fall in the blood pressure for a long time, if there is a drastic fall in the hemoglobin levels because of the blood loss, or sometimes we have to ligate, we have to tie the local blood supply, so then can also lead to the loss of the blood supply to the spinal cord. And sometimes it can also happen in the post-operative period also, if there is a collection of blood inside the spinal canal. But the important is that we can also prevent it. We can take thorough precautions. We can assess, as a surgeon, we always assess these patients carefully and thorough preoperative assessments. Some types of scoliosis, particularly if they're associated with some syndrome, the other systems anomalies like kidney, cardiovascular, or other problems. So there is a higher risk. We have to document the preoperative neurological status. So we have to look whether there is any pre-existing neurological problems. And there are certain clinical signs by which we can see that there are some neurological changes or there are neurological deficits. So these patients, they're also at a relatively higher risk of neurological complications in the scoliosis correction. The question arises whether do we need MRI or not. The purpose is to rule out the other brainstem or the intraspinal anomalies. Sometimes by birth, these patients may have some pre-existing spinal cord malformations. Their spinal cord may be low-lying. That means that the spinal cord is much lower as compared to a normal person. And then there could be some other anomalies. And if we look at the adolescent idiopathic scoliosis, the incidence of these anomalies is quite less as compared to the other types of scoliosis. But MRI is a must in certain situations. If there is a left-sided curve, that means the left shoulder is higher than the right in most of these cases. If the curve is rapidly progressive, if there is a hump also, this we call this kyphosis, if there is a back pain, if there is a history of headaches, if the neurology is not normal on the clinical examination, then MRI is a must in these situations. Now, when we are doing this surgery, now we have intraoperative neural monitoring system. So this is a very useful tool by which we can find out whether there is any neurological problem occurring during the surgery. So this has made the scoliosis correction quite safe and quite predictive during the surgery. Now, what we can do in neural monitoring, we can track your motor nerves, or we can also track your sensations. So But we need a special type of anesthesia for this neural monitoring. Normally, we use some inhalational agents and the muscle relaxants for the normal persons, for the normal surgeries. But when we are using this neural monitoring, then we require a special type of anesthesia. That means it is a total intravenous anesthesia, and we do not give the muscle relaxants when we are doing this intraoperative neural monitoring. So there are basically, as I just told you, there are two basically main types of neural monitoring. We can monitor your sensations, and we can monitor your motor nerves or the muscles during the surgery. So what do we do for sensations? So basically, we stimulate. We put some electrodes on your different areas of your body, and then we give stimulus, and then we record this stimulus from your brain area, so we can tell that the nerves, they are intact because they're able to travel from your the site of stimulation to your brain. So this is how we measure these sensory potentials during your surgery. While in motor areas, we stimulate your brain, and then we record the activity in your muscles, whether the stimulation from your brain is able to reach the stimulation, the site of the activity, that is the muscles. So we can monitor the individual muscles, and we know that the individual muscles is supplied by particular nerves. So we can find out if there is any damage. So what level, or what are the nerves which have been involved. So if we look at the data from the literature, we have seen that these sensory and the motor evoked potentials, they have different type of sensitivity and specificity. The motor potentials, they are more important, they are more sensitive and specific. But if we combine them, and then we have other forms of neural monitoring also, then the sensitivity and specificity rises quite significantly. This is same like the air traffic controller or a system or a smoke alarm system. Whenever there is any problem, then these neural monitoring, they can tell us that something has gone wrong, and then we can take an action immediately. Now, sometimes what happens, whatever signals we are recording, they just disappear, or if there is a drop in their amplitude, or if there is a change in the morphology. If there is a drop in more than 50%, then we take it as significant. And then we have to also look for whether the blood pressure is normal or not, whether the temperature of the patient is normal or not. Sometimes by mistake, some anesthetic drugs have been given, which is interfering with your neural monitoring or not. And sometimes the wires, they may just get pulled off. So there could be technical problems also. So we have set up protocols to how to deal with these signals. And the surgical team, basically, they stop whatever they were doing, and they look for any cord compression, whether the screws are okay or not, whether there's any compression on the spinal cord or not. And then if we have just put the correction, then we also consider it that we can reverse the corrections. We also look for the different the protocols by our neurophysiologist. He look at he look for the repeat recordings of these potentials. They also look for the types of changes. And the anesthesia also, people, they also look for the drugs whichever they have given. They also look for the blood pressure, because it is important to maintain the blood pressure more than 80 millimeter when we are doing these corrections. They also look for the position of the limbs, and then all the teams, they decide together what is to be done best in that case. So what is the outcome after neurological injury? And the long-term recovery, if any neurological complication occurs, is quite unpredictable. And the complete recovery has been recorded in approximately 60 to 70% of the cases. And the important thing is, if the cord injury has occurred because of the loss of blood supply, then it has got poor prognosis as compared to if it has got from a screw or this thing which has been replaced. So what, as a patient or the family, what you can do, you can understand that there are risks involved in the surgery, but it also depends upon the patient's profile and the nature of the procedures, because sometimes if you're planning some drastic procedures, some major procedures, they have got a higher risk. And it's not just a cosmetic problem. We should understand the risk of progression with age as well. choose your surgeon and hospital wisely. It needs a teamwork, so it needs a good surgeon, good anesthetist, and a neurophysiologist. And the surgeon experience is obviously paramount. We have now various gadgets which can improve the precision of the hardware placements. But again, the risk, they get minimized, but still they are there. And these patients, they also require ICU support, rehab, and physiotherapy in the postoperative period. So all is not lost, even if there's a neurological deficit. As such, neurological deficit in AIS is very rare, especially in the hands of the experienced surgeons. And if it occurs, there is a chance of recovery up to 1 year. And with aggressive rehabilitation, we can avoid the problems of lying down in the bed. Thank you.
That was great, Dr. Garg. Thank you very much. I hope that answered a lot of people's questions. If not, please send in your questions so we can address them at the end. Our next speaker is Dr. Robert Lark from Duke University. He's going to talk about infections. Dr. Lark.
Thanks, Phil, and thanks everybody for joining in. There's a little bit of a delay on allowing me to advance the screen here, so give me just a second. There we go. So as we get going, I kind of want everybody to understand what an infection really is. We need to understand that there are trillions of bacteria that live on our body, and actually 10 times more bacteria than healthy human cells. And it makes up about 1 to 3% of our total body weight. So if you put that in real pounds, if you're a 200-pound individual, 6 pounds of that can be bacteria. So make sure you tell your personal trainer that all that's body fat, right? But we need these bacteria. They're needed for normal human functions, such as digestion. So we get faced with different terms like colonization or infection. And I want to try to go on to that next one. There we go. So colonization is when we have normal bacterial flora that live on us. And contamination is a term we used when that microorganism has been introduced into a tissue sample from an external source. So for example, if you take a fall and you skin your knee and you go to the doctor, if they just swab that area where you fell and put it on a culture plate like you see in the picture, it can grow a bunch of different bugs that aren't necessarily causing any kind of harm to you or any kind of infection. So the infection is actually the presence of these bacteria causing damage to your body tissues. And it normally occurs in the presence of acute inflammation. And unfortunately, in a post-surgical state, you're definitely in a state of acute inflammation. So the stages of infection begin with how the bacteria get into your body. Obviously, if you're having a surgical procedure, the port of entry is most likely the surgical incision. And then there's a prodromal period where the bacteria multiply, and they can cause some mild symptoms, redness around your incision site. But once they've multiplied enough and occupy enough space, then they make you sick. And the symptoms are specific, obviously, to the site and type of bacteria that you have. And then once your body kind of starts to fight this infection off, or you get help from antibiotics or decreasing the bacterial burden through a surgical procedure to try to remove it, your symptoms start to decide and you convalesce back to your normal healthy state. So what's the risk? Most studies quote 0.5% to 1.5% risk of a surgical site infection in AIS. And I kind of want to put that in context because nearly 3/4 of our patients will experience some sort of GI distress, whether it's nausea, vomiting, or an ileus after this surgery. Dr. Bonfield's going to go a lot farther into the risk of blood transfusion, but a lot of studies quote risks in the 10 to 25% range. And as you just heard from Dr. Garg, the risk of neurologic injury is even much less. But also try to put it into context of normal daily life. If you look at the automobile industry here in the United States, there's actually a lifetime 1% fatality risk of being in an automobile. And it's estimated that the average American would be in some sort of minor car incident about once every 18 years. So over the normal lifespan, you actually have about a 400% risk of being in a car accident. And in honor of the season here in the States, risk of catching the flu is somewhere between 5 and 20%. So unfortunately, a lot of the studies that we have relating to infection in AIS are small. So we don't have super great data. Most of the studies that we'll see are this level of evidence, level 3, 4, or 5, with greater recommendation, grades B or C. And C is very common, unfortunately, where we have conflicting evidence. So, for example, one study may say that using a surgical drain is beneficial, and then you'll find another study that says it's not. So what can we do to try to prevent these things? Well, obviously, the best way to prevent having a surgical site infection is not having a surgery. So try to wear your brace. But if you have to have surgery, there's also things we can do. We can optimize our nutritional status, make sure we have plenty of protein, vitamins in our diet. Please, please, please tell your surgeon about any comorbidities, no matter how minor you think it might be. Things that are especially important are histories of infection or diabetes, or if you have urinary tract infections frequently. And we definitely need to know a lot about any allergies you may have, especially to antibiotics, as that may change our management. A lot of big centers now are going to providing patients with an antiseptic soap called chlorhexidine that they're instructed to bathe with the day prior to surgery. And some sites are also doing chlorhexidine wipes in the preoperative area on the day of surgery over your surgical site to help decrease that bacterial burden. While we're in the surgery, we're also doing things to try to minimize and prevent infection, the most important of which is the appropriate timing of getting a preoperative antibiotic. And then if the case runs long enough, redosing it if it's necessary. Surgery is not a race, but we want to be as efficient as we can. So we're coming into that room with plans A through D already mapped out in our heads. We know what implants we're using, which levels we're fusing, what our graft choices are going to be. And this will help us minimize our blood loss. We have other methods of that Dr. Bonfield will get into. Temperature in the room is important, as Dr. Garg mentioned as well. It can affect our neuromonitoring, it can affect blood loss, and it can also affect our infection rate. We want to minimize how many people are coming in and out of that door. We want to wash the wound very well prior to closure. There's been a big trend in moving towards adding antibiotic powder into the wound or to your bone grafts, such as vancomycin powder or gentamicin powder, to get a supratherapeutic level of antibiotic locally in that surgical site, and then the use of postoperative surgical drains. After the surgery, there's not a whole lot we can do. You're going to get 24 hours of antibiotics, which is typically 3 doses. Anything more than that's not really been shown to be helpful. Another thing we try to do is minimize the dressing changes. The dressing that's applied over your incision in the operating room is the cleanest one you're going to have. So unless it gets soiled by some fashion, we try not to change it until you're discharged from the hospital. So there are best practice guidelines published on preventing surgical site infections in high-risk pediatric spine surgery. I do want to let you know that this chart is for all pediatric spine surgery, not specific to idiopathic scoliosis. And it was basically a Delphi method of polling a lot of experienced pediatric spine surgeons to get an agreement on things that we can do to try the risk of infection. So the ones published in this chart are the ones that the respondents either replied as a strongly agree or agree. These are practices we all use. So if it happens, when does it happen and what bugs are responsible? So we kind of divide these things into an early or late infection, with early being defined as less than 3 months, late more than 3 months. Please understand that if you get an infection less than a week from your surgery, it is most likely not related to the surgical site. It's from other things. After that 7 day and before 90 days, the most common organism is the flora that lives on our skin, most commonly coagulase negative Staphylococcus. If you get a late infection, so something after 3 months, it can be indolent for quite a long time. Some studies documenting even up to 12 years after the index procedure. And those infections are typically from bacteria that are much less virulent, such as Cutibacterium acnes or Propionibacter acnes. Thank goodness MRCS so far is not a very common organism in adolescent idiopathic scoliosis surgery. So how do we diagnose it? Remember that it's very common to have low-grade fevers for the first couple of days after surgery, just your body's acute inflammatory response to having a big operation. I'm talking fevers 99 degrees Fahrenheit, 100 degrees Fahrenheit. Within that first week, the higher fevers are most likely related to something other than your surgical site. So either developing a pneumonia in your lungs or a urinary infection, which can potentially be related to urinary catheters. But after that first week, if you start to develop new onset of fever, especially greater than 101.5 degrees Fahrenheit, start to feel ill with myalgias and malaise, start to develop redness, swelling, or drainage around your incision site, and probably one big hallmark is your pain's been getting much better, and all of a sudden you're starting to have more and more back pain. Those are red flags to get back in to see your surgeon to make sure we don't have an infection going on. So when you do show up, we're more than likely going to order some blood studies to look for an infection, including infections in your blood with a blood culture. And imaging studies can help guide us as well. So x-rays can show us if there's any loosening around the implants. Ultrasounds and MRIs can show us areas of fluid pockets, et cetera, that may be sources of infection. So if the unthinkable happens, then you're unfortunate and get an infection, all is not lost. We're back to the operating room because we need to irrigate that wound, get as many of the bacteria out as we can. There's a debate on whether we take the hardware out, and I'll show you a slide on that here in a second, but we have to remember that although the nice implants that we have now can really provide excellent correction of your scoliosis, the main goal of that hardware is to hold things still so that the fusion can occur. So if you take the hardware out prior to that fusion occurring, then there is a risk of the curve coming back. You're more than likely going to be on IV antibiotics for several weeks, and then possibly long-term suppressive antibiotics for up to a year prior to coming off and seeing if the infection has been eradicated. So this was a study out of Toronto looking at their pediatric spine surgeries. I'm sorry, it's a really, really busy slide, but they basically had 35 patients that had an infection and pulled them out into implant retention and implant removal groups. And as you might imagine, the implant removed the patients that had but even then, the patients that did have moved did show progression rate of up to 6 degrees. Whether the implants were retained or were not. So, excuse me, in conclusion, is prior to even getting in the operating room, we're going to follow practice guidelines, and our outcomes after infection good. Remember, they may require implant removal to completely eradicate the implant. Thanks so much.
That was great, Bob. Thank you very much for that. I'm gonna have a hard time figuring out what I do with all those bacteria living in my body. The next speaker is Chris Bonfield from Vanderbilt University. He is a neurosurgeon and a spine surgeon. He's going to talk about management of blood loss. Chris?
Thank you, everyone, for listening today. We're going to talk about the third of the big risk factors in the scoliosis surgery, blood loss. And as you've heard from the last talk by Dr. Lark, another risk of surgery is blood loss, with between 1 in 10 and 1 in 3 or 4 needing to have a blood transfusion. These are patients undergoing surgery to have a transfusion into the operating room or even post-operatively as we manage things going forward. So we're going to discuss a few things. One is preoperatively, what kind of labs can people expect and what kind of conversations do we have about blood loss? And also, what do we do during surgery to try to prevent blood loss in general and try to keep those blood transfusions as small as we can. So keep in mind that this is talking about general ideas and techniques that surgeons can use to reduce blood loss. Each surgeon and surgery is slightly different. And so if you have specific questions about how your surgeon does some of these techniques or what he does or she does to prevent blood loss, talk to them specifically. So why do we talk about blood loss? Well, scoliosis surgery is a large surgical procedure. You know that the incisions can be lengthy, going down sometimes most of the patient's backs. It can also be a surgery that can last multiple hours. And so when you couple a big incision with a long operation, generally speaking, that leads to blood loss. But why do we care specifically about that? As it turns out that these 3 risk factors we talked about, infection and neurologic injury and blood loss, are not separate. They're oftentimes combined, and more blood loss can lead to more complications such as increased infections and wound healing issues. If there's less blood in the system or the tissue isn't as healthy, then it can't heal quite as well. You can have organ injuries outside of the spinal cord, such as heart or lung or kidney injuries. Neurologic injuries, Dr. Garg talked about that earlier, is that if the blood drops so much and the blood pressure drops, sometimes you can get spinal cord strokes. These are extremely rare, but these are things that we worry about how blood loss impacts our entire operation. Even beyond that, studies have shown that increased blood loss in patients can lead to longer hospital stay. So it takes you longer to bounce back from these big operations if you've had more blood loss during your operation. And it also can lead to increased costs for your hospital because you're staying longer and there can be other complications. So these are general reasons about why we care about blood loss in these large operations. Furthermore, why do we care about blood loss? You can have transfusion risk. So every time that you get a blood transfusion, there are risks of obtaining those blood cells, and they can be mild, which is most of them. And most of the mild reactions is something like maybe a small skin rash, maybe a fever. You can sometimes feel cold. The vast majority of blood transfusion never lead to any reactions though, so that's the good news about this. And if you do have one, as I said, some are mild. There could be some more serious reactions, and this is why we do blood typing. So whenever you have preoperative labs we'll talk about, you'll know which blood type you are. And we want to make sure that the correct blood type is transfused with you so your body doesn't react to that new blood that's given to you. You can also have other complications such as trachea, which is a lung injury that results from having blood transfusions as well. And in this day and age, all of the blood is tested very well. And so the risk of getting diseases such as HIV or other diseases are between 1 in 10 million and 1 in 3 million. Back multiple years ago, those risks were much higher, but nowadays with blood banks and other things, we test these blood products very well, and so the risk of obtaining diseases is very, very low. So before surgery, blood loss, what can we do beforehand, or what are you going to talk to your surgeon about when you're in clinic or in the preoperative clinic getting your labs drawn and talking to the people that are going to be doing your operation? We'll first draw multiple different types of labs. We want to know what your blood counts are to start so we can follow them through the surgery and through the hospital stay. We want to know not only that, but there's also specific labs that we can draw that tell us how your clotting factors are. And so there's times in the operating room your blood is going to naturally clot on its own, and we need to know that you're able to heal and clot just like we would want you to in surgery. And so there are different clotting factors and clotting labs that will get drawn as well. We'd also perform some sort of type and cross, meaning they take your blood and determine what blood type you are and other different markers on it to ensure that whenever you get blood that's transfused to you, if you need it, that it's compatible with your system and your body doesn't react to either a different type of blood type or other markers that are on the blood. They're going to talk to you about different medications. Most patients who are teenagers are not on blood thinners, but there are some that are, and so your doctor and providers need to know if you're on blood thinners because those will need to be stopped at some amount beforehand. There are different type of medications such as ibuprofen and Advil that also we usually stop generally about 5 to 7 days before the operation in order to make sure that your blood can clot to its fullest. There are also some supplements that sometimes we give patients beforehand. Iron helps your blood count increase. And if you're a person that has low blood counts to begin with, your doctor may put you on iron preoperatively for a little bit of time, maybe weeks to a month beforehand, to make sure that your blood count is up to where it needs to be. EPO is another medication that sometimes people give to boost blood counts in certain settings, not all the time. And also, depending on where you are and what the regional system is, sometimes patients can actually give blood from themselves to store away a couple weeks before the operation, and then that blood can sometimes be used during the operation as well. You're going to talk to your doctor about different family histories of bleeding disorders. We need to know if your mother or father or grandparents or brothers and sisters have a history of clotting or bleeding more than they should be. This is important to know, especially if you haven't had surgery before. We'd also want to know if you did have surgery before, if you've had your teeth pulled, did you have problems with clotting after that? Or if you've had an orthopedic injury or other type of surgeries, how did you do? Maybe you had your tonsils taken out. We need to make sure that you didn't have any bleeding problems with those operations. We're going to talk to you about the procedure itself because that changes how much blood loss we can expect. Blood loss increases with the numbers of levels fused. So the more levels of bones that we incorporate into fusion, that means the bigger operation and the longer time, that leads to more blood loss. Blood loss increases with more bone cuts. So if you have a very large curve or a very stiff curve, sometimes we talk to you about making bone cuts in your spine in order to make it more flexible to correct those curves. Each of those things, the larger curves or more bone cuts, will also add to the expected blood loss that we'll see during surgery itself. So not only will we draw labs to know different things about you, but we'll talk to you about your family history, about your other medical problems, about what type of medications. And furthermore, we'll talk about the actual procedure itself to try to give you some idea about how much blood loss we think may take place in the operation. There are multiple things during the operation that we do to try to prevent blood loss as much as we can. This starts even as much as when we get into the room. The room may be a little warmer than you may think an operating room will be, and that's because we don't want it to get cold. You just heard from Dr. Garg and Dr. Lark that decrease in temperature can lead to infections and also neurologic injuries and monitoring problems. So it also leads to some increased blood loss as well, because you can't clot nearly as well when the room is very cold. So we'll keep the room warm. On the table, sometimes we use special spine tables. This is a picture of one of those. You can see that the blue pads are, one will go on your chest and one will go on your hips as you're flipped onto your stomach. And there's the white and yellow face mask that sometimes people's heads rest on. There are different ways of doing this, but that's one of the ways to do it. And you'll notice that between the chest roll and the thigh pad, it's open. And that's so that your stomach can sort of hang in that area and decrease pressure in your belly, so that doesn't increase the veins and pressure, which could also lead to increased blood pressure and increased blood loss. So we do everything from positioning you on the table to keeping the room warm to prevent this. We control blood pressure throughout the case. And sometimes during the operation, that likely at the beginning and the end, when we're just exposing or closing the incision, we can let the blood pressure go down a little bit. We monitor this the whole time to make sure it doesn't go too low, however. And during the time of the operation, when we're actually correcting your curves, we sometimes raise that blood pressure to make sure that all the blood gets to the spine as it's being stretched or moved. We can also use medications in your IV from the very beginning of the incision, and even sometimes before. That'll help you clot. One of the main ones we use is called TXA, and that's been studied in various groups with scoliosis surgery in children and some adults and other orthopedic procedures, and that's shown to decrease blood loss in the operations that we do. We can also do other things. Sometimes we'll draw blood off at the beginning of the case and give some fluids back to you to keep your blood pressure high. And then as you lose blood throughout the case, give it back to you. That's not done in every surgery, and that's not done in every hospital either. But these are just other options that we have sometimes to try to prevent blood loss, and more so prevent giving you blood that's not yours. We have other techniques. Careful surgical technique is the most important thing when it comes to blood loss. Your surgeon has to realize that this is an important factor of the operation and spend time to prevent blood loss during mainly exposures, bone cuts, and in closing. We have tools that can help us do this. The picture down below with the white object that looks like the pen, and the green object that has two little fingers at the end of it, help us cauterize. And so there's currents and heat that go through those. And so whenever we see small blood vessels that are bleeding or muscle areas that's bleeding, we can use these cautery tools to stop the bleeding. We have hemostatic agents, which mean agents that can stop blood from bleeding. Sometimes that's wax. If there's some bone bleeding, we have things like foam or liquids that we can spray or inject onto these areas as well to try to prevent blood loss in the operating room. Furthermore, we have the machine, which you see there. It's called a cell salvage or cell saver machine. And what that does is when there's blood loss in the operating room, we have suctions, and it can suck up the blood into that machine. And oftentimes they can filter that, spin it down, and give you your own blood back if you need blood as we go through the operation. There's also other things that are now being studied. Sometimes we can inject pain medications into the incisions beforehand. If you do it with enough volume there, sometimes that'll create a little less blood loss during the incision. There's other bone cutting instruments that move at a very high rate that also not just cut bone, but they can also cauterize the bone as they go through, which we think with studies is decreasing blood loss in there. And ultimately, if the surgery is a very large operation, or it's going to be done from the front and the back, or it's just that there was a significant amount of blood loss in that operation, sometimes we actually can stage surgeries where we'll do a lot of the work up front, stop the operation, close up, let you heal, let your blood counts recover, and then go back to the OR on a separate time. This is something, generally speaking, that you'll have talked to your surgeon with beforehand. So when we talk about blood loss and scoliosis correction is a large operation with the potential for significant blood loss. Increased blood loss can lead to more complications, and that can lead to anything from infections to having neurologic injury or other things like that. Good surgical techniques, different medications in the operating room, and cell salvage can limit your exposure to donor blood products, so blood products that are not your own. And with good planning, technique, and monitoring, blood loss can be kept as low as we can, and transfusions are only used if needed. So there is a rate of having transfusions. We do everything we can to try to prevent that, and if we do need a transfusion, to prevent the blood loss, so you only need as much a small transfusion as you need to. But these are the different techniques and ways that we'll talk to you beforehand and deal with blood loss during surgery. So thank you very much.
That was great, Chris. So all three panelists, I think, have done a great job outlining the concerns and how the many steps that we take as a team to try to minimize the risks with what is honestly a big operation. We now have some time for questions. The first question, I'm going to let Dr. Garg answer this. This is from one of the attendees. Dr. Garg, can you comment on the accuracy and usefulness of recording the impedance of the individual screws after they are placed?
Yes, there are some neural monitoring tools we have. We can actually stimulate each and every pedicle screw, and then we can look at the impedance, and we can also look at at what power or what ampere actually we are able to stimulate the muscles. So normally, if we are giving more than 10 milliamperes, so we can say that the screw is safe. Yes, there are methods by which we can comment on their accuracy and the usefulness. Yes.
Now, at my hospital, at least, we were only able to do that with screws in lumbar spine and lower thoracic spine. Are you able to use the screws all the way up, like in the upper thoracic spine? Is there a useful way to do that? I'm not aware of one.
No. So only for the lower thoracic and the lumbar ones. That's true.
Okay. Chris or Bob, do you have anything to add to that?
I think that's great. I mean, I use it as well. And honestly, I look more at the trends of the numbers as opposed to the absolute teens to 20s. And then all of a sudden I have something that's 10. It definitely makes me want to recheck that you're right. The intercostal leads only go up so high, so you can't get into the upper thoracic spine very well.
This is just a question. I think we're all spine surgeons, and so a person who has spine surgery in the adolescent period, as they get older and develop osteoporosis, can these screws no longer be fastened well? I think Bhavuk and Chris, you both do adult some, so I'll let you guys take that one on.
Yeah, I think that if you've had a solid fusion in your teenage years and adolescent years, generally speaking, those hardware is not gonna move. Now, you may have some changes above and below where the fusion is, which is a whole different discussion, but because your bone quality isn't as good or your discs have worn out or something like that. Generally, the only time that I've seen problems with poor bone quality and having a curve recur is whenever a patient had an infection or other things where they've taken the screws out. So they had an operation as a teenager, they fused, the screws came out at a later date for another reason, and then they started having worse bone quality as they've gotten older. And so just because you've got a fusion, it's still your bone. And so if your bone quality gets worse, that can also worsen your curve. You can have problems with that. But if the hardware is intact, generally speaking, it isn't going to move once it's fused and when you get older.
Okay. Just, Bhavuk, somebody must have come in late. They said, what is the risk of spinal cord injury in AIS surgery? I know you had a slide about that, but just so people don't have to scan back, just can you quote the data from the SRS M&M reports?
Yeah, so it's you know, if you look at in the general way, it's around 0.4%. So it's actually quite less. And as such, the neurological complications are quite rare in AIS.
Okay. And then another question is, what someone asked, what is the success rate of surgery? We've talked about all these various complications, all of which have a fairly low incidence, but still not zero. And then other ones that we did not have time to get into tonight. I'm aware of some papers that show that 95 to 98% of people that have adolescent idiopathic scoliosis surgery do very, very well, do not need a second operation then or any time after that. Is anybody, what do other people find, or what do they tell their patients?
So I usually give an analogy, you know, it's same like you go on the road every day. So most of the patients and most of us, they reach our homes safely most of the times. But you know, it's same thing. Anything can happen on road, so anything can happen in the surgery as well. But most of us, they reach home safely. So same with, I can say, with AIS. So this is the usual analogy which I give to my patients.
Chris or Bob, how do you talk to your patient?
Yeah, I think similarly. And as we talk about risk factors or complications like infection and blood loss, you can still have a very good outcome and still not need other operations in the future just because you had some blood loss and needed to have your blood transfused in the operating room. And so we're talking about specific things right around surgery. But overall, when you're looking at long-term results, a year and then multiple years afterwards, most of the patients do very well. But we do talk about these other risks that could take place in the short term during surgery or shortly, you know, in the days or weeks to follow.
Bob?
Yeah, I agree. And I think one of the things is understanding from the patient what they define success as being. I think we're very good at preventing curves from getting worse, which was our original to begin with. So I think from that standpoint, the success rate is extremely high. You know, we do this for health reasons, not necessarily for cosmesis. So I get worried about patients that are worried about having a little bit of rib prominence and other things afterward. And I think as long as everybody understands that, and we've had thorough conversations pre-op, I would say the success rate is incredibly high.
Okay. So we have another question for all of the panelists. What are the risks of vertebral body tethering versus fusions? You know, that is a new and developing technology. I will throw that open to my colleagues and see what they have to say about this.
I've done some, not a lot. I've been very conservative with my indications for this as we're early on in our learning curve for it. I think one of the huge benefits from it is from a blood loss standpoint. I can easily see losing less than 100 cc's of blood for a multi-level VBT case. I haven't experienced any infections yet. And if you look at the literature, it does seem like there's a higher prevalence of getting infection from a posterior approach than an anterior approach. But yeah, I think the jury's still out on that. We've got a lot of learning to do.
Chris, Bhavuk, do you have any?
I also agree with Dr. Lark. You know, still the literature has to evolve, and before we can comment with, you know, which one is better. So I think we are looking at the future. You know, then in the future we'll answer.
Yeah, and I think a lot of that is going to be determined on which patients you can do both procedures on, and then talk about that. So I'm not sure that everybody can get a VBT throughout their life, and so that's important too. Is important what the procedure is, but also what stage of growth and what your curve is, and different things like that as well matter in regards to that.
Great. Another question. Again, this is more generally on scoliosis. Are you guys working on bringing mobility back after reversing fusions? Interesting question.
I mean, I guess it would be nice if you could, but part of the problem with that is that our technique in this day and age with the rods and screws and hardware and bone fusion is that when you're done, all of those areas of bones are basically one big healed block of bone. And so even if you took that hardware out, there's really not a way to restore the different discs and joints and other areas that create motion to your spine. And so I think part of it is knowing which areas of the spine you have to do fusions on and minimizing that if you can. And so if you have one single curve, sometimes you can do hardware right across that and over your whole spine. And so it's a matter of is doing enough of an operation so that it doesn't get worse and it's done safely, but doing as few levels as possible to try to leave other areas for you to be flexible with afterwards.
Same, once we have done the fusion, it is also very important to look at, the other parts of the spine. They are moving in harmony, with the fused spine. So they are all balanced. So it's very important to look at those things also, whatever the flexibility we have left in the spine, it moves perfectly and in perfect harmony.
Yeah, I think you need to remember too, it's not all just about flexibility. I mean, when you have a large curve, especially the curves down your lower lumbar spine that shift your whole trunk over to one side or the other, your balance is off quite a bit. And by restoring that to midline, you may sacrifice a little bit of individual motion loss, but your overall balance improves. So it's a question we get a lot, and it's something we're working on. And I think we need to maybe start looking more at our functional motion as opposed to just looking at individual motion levels.
Okay. Another question. I would like to know how scoliosis and spinal fusion change as we age. What side effects or problems can we expect as we get into our 60s, 70s, and beyond, and what treatments are available to address them? I'll throw that open to Dr. Garg and Dr. Bonfield. I think Dr. Lark and I are pediatric spine deformity doctors, and so I really don't have a good, I will leave it to others.
Yeah, so what we worry about is that if you have your thoracic spine and part of your lumbar spine fused, basically the question is what happens to the areas above that up into your neck, or what happens into your lumbar spine down below. And naturally, as we age, you get arthritis and you get changes in your spine. You can have your discs that wear out a little more. You can have spinal stenosis, and your ligaments and joints can be inflamed as well. And that's just part of life with or without scoliosis operations. Sometimes because there's a little extra stress on that area in your lumbar spine, if it's not completely imbalanced, maybe that could be faster in you versus somebody who didn't have an operation. But I think a lot of it is going to be what your genes are. If you've had family members that have all had spine operations, then probably in your genes, it's that your spine wears out a little faster than others. The other thing is how you take care of your body. So are your core and back muscles strong and flexible? Have you maintained good body weight, and have you maintained good bone quality as well? Because these are all things that people with or without scoliosis and with or without scoliosis fusions can lead to better spine health in the future as well. But certainly there are lots of patients who have had the scoliosis operation, and that is it. And that's what we're hoping for. But we have seen some in our adult clinic that have needed the spine surgery and fusion to be extended either down lower or higher, just because those part of their spine is sort of worn out as they've gotten older. But again, for trying to prevent all those things, it's the good spine health stuff that we always talk about and always preach that's going to help out in the most with this. You also have to remember that if you didn't have spinal surgery and your curve was very big and your balance were off, then you're going to have more problems in the future, and the problems are much harder to fix when you get older as well.
I fully agree with Dr. Bonfield. The risk of AIS progressing into the adulthood with the degenerative conditions superimposed are much more as compared to with the corrected AIS. So I think the problems are much less if you have undergone surgery for AIS earlier in your childhood.
Okay. We have another question, and this is someone asking about having reduced ability and pain after in the rib cage after an anterior scoliosis correction. Let me just point out that we can only give general answers. We don't know all of the particulars. We don't know a lot of the details. So please, the questionnaire, please understand, we will do the best we can, but we are the best person to ask these questions of is the doctor that did the surgery. So rib pain, chest cage, I'm sorry, rib pain and problems taking deep breaths 6 months after anterior spinal scoliosis correction. Don't everybody jump in at once.
I mean,
I think
you're having to oftentimes remove a rib for that. You're going through the costovertebral junction, sometimes putting stress on those areas. Fortunately, we don't do a lot of anterior surgery anymore. I think with vertebral body tethering, we may see more of that coming down. But yeah, I think that'd be a great question for the surgeon that did the case. I haven't experienced that very much in my practice.
So if we look at the rib pain in the anterior surgeries, it's actually, you know, sometimes if there is a neuroma formation in the intercostal nerves or this thing that can cause a prolonged rib pain. But most of these cases, they usually, these pain, if it is there, it subsides within a year or so. But if it persists longer than that, and if you can point out that there is a particular point at which you just put your finger and then the shooting pain, then it may be a problem. And if it persists for more than a year or so, then there are specialized procedures which you can excise those neuromas, and then we can treat that.